Melissa. So as we lead into this next, we're going to do a panel session again that I'll facilitate. And this time we're talking about the conversation that sort of started with Catherine and to Claire and now to Melissa. So these different perspectives are important. We're talking about the role of the hospital in the medical neighbourhood. And Melissa's story powerfully reminds us that the role of the hospital in the medical neighbourhood goes well and truly beyond the notion of bricks and mortar and policy and funding. But if we are thinking about bricks and mortar and policy and funding, we think about in the context of why. Who are they for? What benefits? Who decides what those benefits are? How do we seek those fire-starting relationships? How do we actually invest care into that journey that we're creating through our policies, our funding proposals, our business models? So the conversation today, we've got 4 on our panel, and once again the format will be similar to yesterday. We'll actually have 2 of our panel members to give us a brief 5-minute intro, their version or their sort of key 3 points that they want to present in relation to what they see as the role of the hospital in the medical neighbourhood. They have 5 minutes each, and then we open to a panel discussion. What we've added today to try and bring you into the conversation more, you might see the mics at the end of the panel. We'll give it about maybe 10 minutes or so at the end. What I'd do is to invite you to actually ask questions of the panel. In order to facilitate that, could you just jot down what you're thinking as we go, so you've got that ready to go. So we don't want people to have something that's really burning that they don't get a chance to ask, although as you can appreciate with time constraints, we may not be able to get to all questions, but even the act of writing the question, I think, is an informative process. So can I actually please ask now our other panellists to join us on the stage? We have Claire Jackson coming back, Siddiqi and Ruben Flores. So to kick us off, as I said, for a sort of quick 5-minute passionate presentation in relation to what they see as the 3 key aspects of the role of the hospital in the medical neighbourhood. We're actually going to hear from Sameen and Ruben. Could I please ask Sameen to kick us off?
Before I think I have to say something, let me first acknowledge that we've heard 3 very good and amazing presentations. One was from a policy perspective. One was a very strong academic perspective, and I think we can all see it was the third one was a very moving patient's perspective. I'd like to acknowledge all the presentations that were made this morning, actually, But they were all coming from very mature, developed health systems. Perhaps I'll spend the 5 minutes that I have in discussing perhaps countries where I have worked and which are perhaps less mature and less privileged and less well-funded. And the challenges, of course, there are very many. Of course, we're talking about the medical neighborhood, which to me, coming from a very middle-income country or a developing country perspective, is more about how do you do coordinated care, better communication, better decision-making, and better collaboration in order to have better patient outcomes. What perhaps we have been calling this is more integrated care, and I think we heard this morning as well. So I have to say that the idea of a medical neighborhood has not necessarily permeated the countries which are perhaps the low-income countries or middle-income countries. But there is, of course, years of experience of what we call attempts towards integrated medical care, or healthcare for that matter, Now, I think from a perspective of these countries that I have experienced with, the Middle East, North Africa, South Asia, I think there are some global health movements that I'd like to spend a minute on. Today, if you go to these countries, I think a lot of them are talking about SDGs, the Sustainable Development Goals, and they're talking about Goal 3, which is the goal for health and well-being. There is also a global movement on what we call universal health coverage. And in about 2 weeks' time, we will have a conference in Astana, which is next to Almaty, on a reaffirmation to primary health care in the form of a Astana Declaration 40 years from Almaty. And so all of these are saying perhaps or sending similar messages. So a integrated healthcare message in these countries I would like to see should be aligned to these, because a lot of these countries are actually very much committed to moving in that direction, I would like to take the benefit, of course, my own university, and I think 37 years ago, after Almaty in 1981, the Aga Khan University actually held a global conference on the role of hospitals in primary health care. And I think that is one of the landmark conferences. Unfortunately, I think in the last 30 years, the role of hospitals has not necessarily been mainstreamed in the work on primary health care, and perhaps we can, in the discussion, talk about it why. But there are many of these challenges. Now, if I look at some of my countries where I've been working, there are many countries we have major programs of community health workers. I mean, there are countries where there are 100,000 community health workers in a country. And I think they are in some ways reflecting the elements of medical neighborhood, or I would call integrated health care. Their outreach programs. And I think they have actually had a difference or an impact in terms of making health outcomes. But there are some barriers, and I think I'd like to touch on a few before I close. And some of them are, of course, the healthcare delivery systems still remain quite fragmented, and the services are diverse. There's also a lack of staff. I mean, if you want to do coordination, if you want to do communication, you need resources. And while everybody likes communication and coordination, but not everybody now wants to be coordinated. And that's been my experience, actually. Also, in many of these situations, there is challenge of infrastructure, information technology, interoperability of these systems, and also there are funding challenges. And I think we heard very clearly this morning about incentives. And so countries that rely heavily on direct payments or out-of-pocket payments, which have really not moved to prepayment systems, these challenges are there. And so we have to move in our countries from a competition. Competition is good, but sometimes of unhealthy competition to a greater coordination and collaboration. And I think many countries are moving in that direction. Many countries are moving towards universal coverage, and I think that as they move, their care becomes much more coordinated. But many, many challenges remain. So in the end, I think if we would be able to overcome these barriers, to be able to bring more collaboration across the various stakeholders, whether it is the hospital, the primary care facility, the diagnostic facility, the social services, and of course, not to forget the community, the patient, and the family, then I think we can certainly move towards having much more integrated care with better patient outcomes and better results. So I think I'll stop here and then we can have more discussions.
And now, Ruben, to continue the conversation.
A pleasant good morning to all of you. It is indeed an honor and a privilege to be given the opportunity to participate in the 42nd World Congress of Hospitals by the IHF here in Brisbane, Australia. The topic, redefining the roles of hospitals in the medical neighborhood, is a topic that is really close, especially to us in the Philippines, because as you may very well know, we are now in the process of approving into law the Universal Healthcare Bill. The main goal of the Universal Healthcare Bill for the Philippines is actually to see that every Filipino family has access to primary care. All primary healthcare providers shall then have the sole responsibility of gatekeeping the health system. In that, it will ensure that every patient will have access to the appropriate care at the appropriate level of care and at the appropriate time. In that bill also, it is important to note that there is a section that provides for the definition and establishment of a service delivery network. The medical neighborhood concept is more or less akin to the service delivery network as defined in our proposed law. And the learnings that we will be able to get from this session, I think we can aptly put to use when we go back to the Philippines and implement our Universal Healthcare Bill. Okay. This is a very simple slide which I called out from a WHO document. And it defines the 8 components of good service delivery. And benchmarking the good neighborhood concept with the SDN, Service Delivery Network of WHO, you can very well see that they have common requirements. First is coverage, accessibility, comprehensiveness, accountability, efficiency, coordination, patient or person-centeredness, quality, continuity. Okay. In closing, since we are only given 5 minutes, this is just a diagrammatic representation of the 21st century healthcare we are about to face. We know that the 21st century healthcare will be very much influenced by informatics, advances in medical technology, as well as in science. At the other end of the balance, we should always be reminded to look back into the history of hospitals. As you very well know, hospitals came from the word hospice, a haven for the weary traveler. And the patient-centeredness of the service delivery network that we are going to establish will ensure compassion and care and the provision of services that is humanistic, patient-centered, and with dignity. So with that, we hope that we will have a very fruitful interaction. Thank you very much.
Thank you, Ruben. I want to take a leaf out of Claire's book as we start this conversation at the macro and work our way towards the micro, and then it might be an appropriate place for us to start is this concept of incentives, changed incentives you referred to, Claire, in your conversation. I noticed that there's 2 things that come to mind, is that the original hospitals that we had, the bricks and mortar that were some centuries before, one of the ways they actually managed to determine patient outcomes was at the end of the day, the staff would leave the building, lock the doors. Whoever was alive when they got back in the morning had continuity of care. Appreciating that we might have moved on just a tad from that particular approach, and also noticing from the organisational development literature that incentive is a very complex thing and is way beyond just money. Could you sort of talk a little bit about what these changed incentives might need to be or must be in relation to this vanguard space we're getting into?
And you're absolutely right, Lindsay. Incentives isn't about paying people differently. There are much more powerful initiatives there. And the first thing I want to say is that in picking up Melissa's point, the issues about every healthcare worker is there because they really want to make a difference to people. They really want to help people. That's what really brings us into the area. It's just that traditionally our focus is we're going to give you great care until you step outside the doorstep, as you say, and then you're someone else's problem. And patients and people and families don't experience health like that. And so what we have to do is incentivise a model of care that will support people to actually take the most active care possible and to be involved and happy with the sort of care they're getting. So incentives really need to focus around that. And rather than looking at different ways to fund people, I think putting KPIs together that would indicate to people in their current roles that they need to think a bit more broadly outside things as part of the expectation that this hospital has about your care. So for an example, when Carol and I first set up 10 years ago, an electronically generated discharge summary which went out to all the patients' community care providers when they left the hospital. And we got patient consent. The first 10,000 patients who were asked if they were happy for us to share information with their community health providers, we had 5 people say no, and that was fine. They were for mental health reasons or for domestic violence reasons. They just didn't want anyone else to know. Fine. So we would then send out, within 48 hours, summaries of the episode of care in the hospital to the providers. And we thought that was brilliant. After 6 months, there was hardly any summaries going out. What are we going to do? So we worked with the team in the hospital, Director of Medicines and others, and they made the KPI for the junior staff, number 5 was, you actually communicate with the rest of the patient's team in the community. And it went from priority level 269 to something that the junior staff recognised was important to their leaders and mentors. And we got up to 99% benchmarking across that. And what do we do? What was the incentive for that? Number one was that the hospital's culture set this as an important initiative. And number two was Carolyn would take a cake around once a month to the ward that actually got the highest strike rate, and we would all celebrate together. Someone from the community would come in and just say how it had changed the patient's story from their point of view, having that information, being able to act in a timely manner. And we actually slowly incentivised the system to really be focusing on what the most important outcome was, which is that person and that family and their health outcome.
And that goes to the concept that Melissa, you talked about engaging patients in the boardroom, which was a phrase that really resonated, which is that often the space where KPIs are conceptually developed. So bearing in mind we're talking about incentives beyond monetary, could you perhaps talk from your perspective about this idea of incentivising from the point of view of what you see as being motivating to create the environment you'd like to see?
So in lots of the hospitals I've worked with, they have incredible incentive programs set up for their staff that sets the standard and goes the extra mile. There are staff champion programs where they're officially recognized, celebrated with. One healthcare system I worked with actually had a trophy, and it would be given out to each unit as seen fit. Once I was actually brought in as an incentive, a treat for a unit that was really excelling, and I got to speak at their meeting and tell them what an incredible difference they'd made in my life because they went into this work for a reason.
It's very powerful. I know the people in the room who have experienced healthcare directly, and they're either providers and or patients, and those roles often can overlap, is that, as you say, we remember the criticisms. We often don't recall the compliments, but the compliments or the appreciation, even in the smallest way, can be incredibly powerful. And it's a question of how do we create ways to build that in. And that moves me to you, Sameen. You talked about something we haven't talked about a lot in this space. We're talking about highly resourced, developed world hospital systems that, as you quite correctly emphasised, are privileged contexts in which to engage these kinds of conversations and responses. So bearing in mind we're still talking about the concept of a medical neighbourhood, we're exploring that kind of macro picture. You alluded a little bit to what you saw as some of the key principles. Can you sort of deep dive? You talked about infrastructure, you talked about low staffing issues. In terms of that. Could you sort of explore that a little bit in terms of what you see in the low and developing income country context might be the really key, for want of a better word, incentives, but...
I can talk about the incentives
yes.
as well a bit. So I think we're talking about, we're talking about systems where you're spending $2,000, $5,000, $8,000 per capita. And I'm talking of countries which spend $150, $200. So there is a 40-fold difference, and this brings in a lot of challenges. But that's not the only thing, because funding is one, but not perhaps the only thing, you know. I think the point that you make, Melissa, which I think you're an epitome of, so the patient voice element in our systems are really weak, and I would very much like to see that the patients have a voice, and so the supplier or the provider is so much driving the systems there. And I would very much like to see that the demand side, if I could use that term, really needs to be sort of brought in the mainstream so that people really listen to what patients are asking, what their voices are, and I think that's a big challenge that we have to work towards in our...
How do you think that could happen?
Well, obviously it requires interventions on both sides, so I think you really need to educate, you really need to educate the patients, inform them, and of course you talk about, health is basically a right. It's not a privilege. It's not something which you buy off, And so that kind of thought process has to go in both from a provider's and policymaker's perspective, but also I think, so the role of civil societies and NGOs in this situation can be quite critical, where they could help actually communities that are disempowered to bring them into to their voice to the mainstream. I think also the media in these situations can play a very, very important role, because the media has a lot of reach and a lot of power. So I think those kinds of interventions through the media, through the civil society, and the academia, because the academia also sometimes is so much into their own work that they sort of tend to lose sight of the fact that I think we need to also look from the patient's perspective. So there are many avenues through which we can actually make a difference to bring more patient voice. From an incentives perspective, this is the way I will see it actually. I mean, currently, the incentive system is such that the more you operate, the more surgery you do, or the more you do, the more incentives you get, basically. I would like to see that it is if in a community you could actually get the prevalence of smoking reduced, then there should be an incentive for that. There should be an incentive for controlling the risk factors for cardiovascular disease in the community. So if that sort of incentive system comes into play, then perhaps it'll be very strong, very good from the community perspective. It'll perhaps bring down the costs as well. And at the moment, that kind of incentive system, at least in our countries, does not necessarily exist. And so I think we need to work more towards that. Rather than, the more you operate, the more you do bypass surgeries, the more incentives you get. I think it should be turned around to be saying, what can you do from a community perspective to be able to bring down the incidence? I think in your countries you have these experiences. Perhaps you've done much better in that respect, and there's a lot of learning to be done. But I think in our part of the world, perhaps we need to do more. So it's happening in many countries, not that it's not happening. I mean, if you look at Thailand, if you look at Turkey, which have done extremely well in these situations. But there are, of course, many countries where this has to, of course, move ahead.
Can I?
Ruben, I saw you nodding
I would like
there,
to
yes.
contribute from the perspective of a hospital manager.
Yes.
In the hospital, we see to it that in the Philippines, we have a scorecard for the hospitals. And we see to it that patient engagement is a vital indicator. So hospitals are actually graded in terms of performance on the basis of the patient engagement that they have, and they are given incentives in terms of budgetary support. So I think that would work for many of our hospitals.
And there's this interesting issue that we have, this challenge on the one hand of having systems which are advocating the principle of health as a right. We're recognising that we're missing the mark in terms of recognising what that actually means rather than just saying it. And I guess, Ruben, I'm just going to ask you to maybe comment a little bit more, because this is a comment that you made about the fact that, this universal healthcare, and it's also, once again, your choice of pronoun was about our needs. So you sort of suggested it as a hospital manager, as a sort of a clinical lens, if you like, into that space. Could you talk a little bit more about how you get from they sort of needs to our? How do you get, this is this cultural shift we're talking about, to this our? How do you bring people, it's a bit like Sameen's comment, how do you bring people into the fact that this is a shared journey? It's not just about the individual and their rights, it's about this collective. How do you, in your experience, feel that we can get to that sort of our needs are being met?
Well, of course, you have to be champion of the principle, and you have to advocate. Being a member of the Philippine Hospital Association and being a consultant in our Department of Health, we can influence them in terms of policy making. So that's what we do. And as far as the Philippines is concerned, we are educating our hospital managers to lead the crusade in providing a caring and compassionate care to our people.
And this is that challenge. Everybody uses the word compassion. Everybody uses the word care. And one of the challenges that keeps coming up, and it's something that you, Claire, alluded to, is this challenge of time.
Timeliness.
Time. It's interesting that it seems to take time to be compassionate and caring. And once again, time is of the essence. It's a rare commodity inside the health system. So opening it up to all of you, and we can jump in and have a bit more of a conversation, because time seems to be often, when you listen and you talk with people, they'll say, yeah, that's terrific, great, love your policy, fantastic, yep, love your mission statement, I have not got time. So how do we build that message practically into this space?
So I'd like to share the experience of the university that I've recently joined, the Arakan University. And so it has a strong community-related work, actually, for the last 30 years. So the department that I chair, we have a community site. So we have a field site, actually. And our medical students and our nursing students actually go to the field sites to be able to see how the communities are organized or not organized. And so a lot of this needs to be done at the level of the undergraduate education, where you have to imbibe and you have to build these values at that level. I mean, you can do it at the managerial level and so on and so forth, but I think it's a missed opportunity if we don't do it at the level of the medical school and the nursing school. And so I think while the traditional medical schools, in my country at least, are not necessarily doing this, but we try and build that model of community engagement right from the first and the second year with the medical student. And I think that's extremely important that we do it then, actually. Otherwise, it perhaps may be a bit too late. And so, for me, that element from the undergraduate level is extremely important for all professions to be able to engage with communities and to see the challenges that the communities face, actually, when they seek healthcare in these situations.
I think culture change takes time. I mean, time's not a bad thing. The bad thing is when you just career along and don't do anything differently. But I think proactively looking forward, knowing it's going to take 3-5 years' time for people to really engage with the change and then make it part of their daily event, that's the critically important thing. And I think the other thing that I feel about culture change is that people in a hospital are not going to change their culture around the community unless they trust those community providers to offer their patients the exquisitely great care that they are getting in the hospital. And so that's why I raised the analogy with all three of those exemplars is they took a lot of time to look at what was in the community, what was strong, what was lacking, working with the community to build those skills and support so that their hospital clinicians would be happy to let go. And another example from real life, we rolled out a neonatal phototherapy initiative where babies born with neonatal jaundice would be able to receive their phototherapy in the community. We had 3 hospitals that were involved in it, and 2 of the hospitals were going gangbusters, were having really good outcomes, the babies were doing well, the patients loved it, and the other hospital wasn't even recruiting 1 or 2 mothers and babies, and yet it was the massive hospital. When we really looked at it, it boiled down to one of the night nurses who always had time, as Melissa said, very compassionate, would talk with the mums, and the mums would say, what do you think about this initiative? And they go, oh, baby's very small, and maybe they're very safe with us. And when we really unpacked that, it was about she was really nervous about what those Brisbane community nurses might do with their GPs to the baby. So we actually got that group coming in and doing in-service with our hospital staff, answering the concerns and worries and really building up a partnership. And we had no problem then. It rolled really well. It was a change in culture around we are confident that our patients are going to get the best in the community, and so we're happy to let go.
So I want to, this concept of there being time enough for compassion, I really think one of the answers to that is this shift in healthcare that we're talking about, the role of the hospital in the community. So when you build that framework, that foundation in patients' minds of what is engaged, like patient activation, the knowledge, the skills, the confidence to really engage in my own care, and letting patients know not just about their disease, not just about their medical issues, but about what it means to truly be engaged in their own care and to be the best patient they can possibly be, making physicians and nurses and providers community ambassadors of health, so that there's already this framework and foundation in place from relationship standpoints, that when I am in the hospital or when I do see my provider, that bridge is already laid and we can quickly come across to each other. I will add, though, as a patient, that the idea that compassion always has to be lengthy and exponentially some dramatic thing, right? I know within 1 minute when you walk in my door, if you are really in this encounter with me, if you've sort of dropped the mask and you're listening to what I say, it can just take a few minutes, but we know.
And that's the thing, I think that knowing is often a part of it, but it's actually having the comfort and confidence, a bit like you're saying about that there's this territorial divide between the hospitals and the community. It's real, it's reinforced in policy. And what I'm curious about, and you've used the word bridge, and also you're talking, Claire, about the fear of what are those community nurses going to do. There's almost this tribal mistrust. So I'm wondering, just in relation to the community of healthcare providers as opposed to community healthcare providers, how is it that we could potentially move into that little subtle but powerful shift in phrasing so that we see ourselves as part of one system with multiple codependent, interdependent moving parts? How do we make that shift, do you think? Sameen?
Well, I wish I had the perfect answer, because that is really the challenge for all of us, you know. I think a lot of it will come from the leadership part. You know. I think we have to bring in the leadership dimension to this discussion. I think, and to a certain extent, I mean, you don't have to be, the hospital doesn't have to lead it. I think when you bring the stakeholders, so there's a hospital, there is the community, there is the primary care facility, there is the diagnostic facility, there are social services. And so I think there has to be a forum where they all come together and talk. And I think in many of the situations, that forum doesn't necessarily exist. Now, in my experience, there are, in our situations, what are called district health management teams. They're not as well represented in terms of the community's representation as I would like to see. And even if they are represented, I think the voice of the communities is not necessarily there. And so I think it is incumbent on the providers and the suppliers to be able to bring them in, you know, demonstrate that leadership, have an open discussion, have open conversations, good communication. And I think that's a good way to start, to bring people together, to be able to start. And that will help understand each other, develop a bit of trust, give voice to the communities, and perhaps help managers to be more sensitive to the needs of the communities, you know. So I think there's no one magic bullet that can actually fix it, but I think it is these kinds of efforts that will perhaps bring these stakeholders together to be able to share the problems that they face and then collectively try and find solutions to these problems.
I see. For the Philippines, we have been trying really hard to establish service delivery networks as an efficient way of delivering care to our people. As I have said, we are enacting into law the Universal Healthcare Bill, and in that bill, it mandates the creation and establishment of service delivery network. And the question is, will mandating it or will an executive order or a law make work in the establishment of the service delivery network? I think there is more to it than just establishing a law. It has to be partnered with a continuous advocacy and information dissemination at the community level and every level. Because you have two sides. You have to deal with the patients and the community as well as the care providers. So they have to meet somewhere and engage.
Yeah, I think that we have to make a conscious effort right now to proactively reach toward each other. I think it's going to come from both sides. And we have an incredible opportunity in transitions of care. You know, one of the scariest times as a patient is not always in the hospital. It's when I'm leaving the hospital to go home with my family that are not healthcare workers, and I have to now learn to live this new life of a sick person. So if we had organizations in place to do those soft handoffs, to come back and forth, to really integrate the care back and forth, I think it would flow naturally both ways, but it's certainly going to take reaching on both parts.
And I think finally when we build any teams, we do team building exercises, and I think doing an active exercise is the way to go. Pull all the team together around a really wicked problem. Really push them to think collectively about, we're not managing to make an impact here, what can we do together? And it just unlocks that potential. The one other thing you must do is give them a one budget to solve it, and don't make it too big, because otherwise you won't focus that innovation. And using the patient as their own case manager, I think, is an enormous opportunity now that we didn't have 10 or 15 years ago. People have got their own home BP cuffs, they're managing their sugars, so they've got their own insulin pumps. There are a lot of things the patient is the expert in. So why are we going and putting extra nursing staff and other staff in there. So really thinking innovatively how we use digital disruption, how we use apps, how we actually use really sexy communication between the patient and family direct to their clinician. Those sorts of things will only come up if you have the team working together on solving a really challenging problem. Once they work on it together, it brings all that positive respect, understanding, teamwork. It's a very good starting point.
And I guess the starting point that maybe thought about was one of the slides you had, Melissa, was Team Melissa, those T-shirts, which was this idea that not just that the patient as case manager and families are involved, but you actually had people on board to the point where you got a series of T-shirts printed. I thought that was pretty cool. And I guess that's the interesting point, which is connecting your two comments, Melissa and Claire, is that thing about, I guess the challenge for me in this space is that there, once again, tribal, is that this notion that patients and their families occupy one territory and practitioners and their systems occupy another, and we've got this almost no person's land in the middle, which we're all learning to try and navigate. What I find interesting from the health provider side, and I'm just curious about your comments about this, about the notion of team. I know in my emergency medicine space that team is learning to work together through repetition around protocols, which is standardisation, which has its place. However, patients are not standardised. I remember in my physiology textbooks we had the 70-kilo man. I don't know how many 70-kilo male patients I've actually encountered in my real clinical life. I'm just conscious that medical practitioners, healthcare providers, allied health nursing, etc., and the administrators who come in that space are often occupying a notion of standardisation which has a certain amount of scientific validity. However, its translatability to the teams that we're trying to talk about in this word wicked, the wicked problems, which are far more complex than we're actually trained to encounter. Could you sort of talk to that a little bit?
Yeah, and I guess coming from a general practice background, that's my everyday, because every patient is different. And as I say, the students in general practice, when you see them once, you get one piece of the jigsaw puzzle. When you've seen them 5 or 6 times in their family, you're really starting to get all the edge pieces and working with them to fill the centre in. So in general practice, we find the traditional guidelines really irritating because you get a guideline for diabetes and one for dementia and one for osteoporosis and hyperlipidemia, and then you get a patient for whom the guidelines really don't work in their personal circumstances, and you have to throw it all in the mix and work with them to make it happen. Whereas the hospitals have to have much more process-driven and careful standards and quality approach because they're dealing with people who are very ill with enormously complex care. So I think it's recognising different settings have different priorities, but always focusing on what are the resources that are available to help this patient. I've got some patients who are missionaries who self-manage very well. In fact, they often come back with better health outcomes because they've lost 10 kilos wherever they've been living and their diabetes is in much better order. And then I've got patients who really take a lot of support and time from all of our team. That's where we should be putting our time in, not the patients who are actually doing quite well with just a little touch of support here and there.
Does anybody else have a comment about that?
Yeah, I think we don't want to have standard operating procedures for this kind of thing, but I think there are certain guiding principles that I think we do need to adhere to, actually. And I think the providers should actually. And I think one very fundamental and basic one is good listening. And I think many as providers, we are not great listeners. And I think listening is absolutely important. We listen to what our patients are saying, and quite often, in our own commitments and so on and so forth, we overlook that part, I think good listening then leads to other things, good communication, and then, of course, coordination, collaboration. So I think there's something to be said about a few key principles that are important in terms of, bridging this gap that we're talking about. But I do agree, of course, we don't need to, every patient is different, every patient is human, and so we don't need to talk about specific standards for that, But I do believe that there should be some key guiding principles, the whole fact that you have what is a consultation time when you see a patient? If you look at some of the primary care facilities that I've seen, it's just 2 minutes, the patient is, the doctor or the physician or the provider is hardly giving time to the patient, and they just might prescribe and then actually. So there are some things to be said about, some principles that need to be adhered to.
I think that it's really important to note that standardization and flexibility can exist within the same framework. As a patient, I've had providers that are incredibly strict in how things move along. But the part that is flexible is that they always meet me where I am that day. So there's this overarching framework of, especially in patient engagement, so respect, dignity, listening, empathy, all of those guiding principles that he spoke to that can certainly steer you through those encounters. And then I think it's also worth noting that we'll begin to flow more easily in the back and forth exchange when we start to proactively create spaces for interaction, like you were saying, and it doesn't always have to be a physical space. A digital space works very well too, but the more we interact with each other, the better we'll get at it.
Did you have any comments, Ruben?
Yeah, I would like to make a very brief comment on that. Well, standards are set by the hospitals to ensure quality and safety of care, but let us not forget that at the other end of the spectrum is the individuality of each patient. So treat every patient as a unique experience.
And that tension is something
Yeah,
that is
exactly.
quite, in the everyday, is the real challenge, isn't it?
Yes.
And in the interest of actually getting some questions from the floors, you noticed we have 2 microphones here. If you have a question that you'd like to ask the panel, can I ask you to start making your way down towards those microphones? Do we have anybody who'd like to actually drill down on some of these issues or cover stuff? There's obviously an enormous amount that we could go into. Is there anybody who'd like to actually ask a question at this point, moving towards the microphone? No one's moving? If you do want to, come to the microphones and we'll make sure that you're heard. Okay. So one of the things that keeps coming up is this notion of partnership and collaboration. All of you have used this word. We've just referred to it in relation to that, recognising the individual in the context of standardised care. And the word that came into this was active partnership. And the importance in that is to recognise what does actively actually mean. Because Melissa, you alluded to the point, it's like, yeah, you can have partnership and you can have this low-level thing, but what really would active partnership, what does it require of us in these vast, often highly standardised and protocol-driven spaces called hospitals?
So when I travel, and particularly when I work with other advisors, sometimes when you ask them, or you'll ask the CEO, do you guys have patient and family advisory councils? And they will optimistically say, absolutely. And then when I speak to the advisors, they've had very little true impact for change. So people like me, like when I work with my local hospital system, I do it for absolutely free. I don't charge because I care so much about outcomes because people like me are seen there. So my incentive is to know that I can truly create change in your organization. That is what an active partnership is to me.
A simple, in some respects, concept, but quite lots of moving parts in that space, I guess. And that's the thing about this. We'll just sort of try and get some comments maybe on that or something else. So thank you for that. We've got one microphone. Yes, your question.
Yes, thank you for the discussion. Harith from Oman. Hopefully we'll see you next year in IHF 2019 in Muscat. My question is, health as a human right goes hand in hand with other human rights, like, or other basic human necessities, like accommodation, food, education, etc. And I think cost is very important. So if we can afford quality, then if we can afford quality and patient engagement, etc., then good. But we need to focus first on the more important things. Those who are hungry, they will not care much about the taste of the food. Those who are homeless, they will not care a lot about having IKEA furniture in their homes. And in healthcare, that also applies. Like the example Dr. Sameen gave of $50 or $100 per capita, I don't think in those circumstances advocating for patient engagement, etc., will be appropriate. What do you think?
So
Sameen, do you want to
maybe-
start?
Sameen first.
So if I heard you correctly, and you said in situations where there are underspending in the health sector, patient engagement may not necessarily be desired. Is that what you said?
The right way to go, yes.
Well, I don't think that's true, actually. And I think some of the best community health worker programs are in countries that are low and low middle income countries. And so I think there is a lot of excuse me, opportunity and need for community engagement, actually. And as a matter of fact, you know, we should listen to the community's health needs in a situation where particularly you have very few resources to what their health problems and challenges are. So for me, actually, in these resource-constrained environments, there is an even greater need for community engagement and involvement. It's not easy. It's time-consuming. You require a lot of patience. You require a lot of effort. But I think we cannot overlook that. So for me, their engagement is absolutely essential and critical, irrespective of the resource base of a particular country.
I absolutely agree. So when I travel to other places in the United States that really struggle with poverty, homelessness, hunger, things like that, those are the patients I meet that need engagement the most. Those are the people who need advocates the most. And I think it's about broadening our sense of what engagement means, particularly in the provider-community relationship. So if you are making a way for me to improve my health, my life, my general well-being, you're doing patient engagement.
Yeah.
Yep.
At low resource setting, it's more needed to engage in community engagement because you will achieve efficiency, you know, and it will lessen the duplication of diagnostic tests, et cetera, that's being done in the highly specialized medical center. And the way to do it really is to establish a system within the neighborhood so that we will be able to operate the system more efficiently. So we encourage you to engage in community activities.
Yeah, I'd probably
Agree.
strongly
Yep.
agree with Ruben's comments.
Yes, another question.
Yeah, good day. My name's Russell McGowan. I'm a patient perspective advisor on safety and quality in health at multiple levels in the healthcare system. But I wanted to take issue with something that Claire said about relative needs of individuals advocating for their own and their loved ones' needs in the healthcare system. I think I was a little dissatisfied with the notion that you can leave some people to themselves, to look after themselves, and you put all of your time into those that are more demanding. I think the concept of equity needs to be considered within the healthcare system, but you've got to look at where you are, the people who are most in need, and sometimes those that are most confident have just as many needs as those who are more insistent about getting services.
I
So
probably
wonder if you
put
could
that
just talk
very
about that.
clumsily, Russell. I guess what I meant is there are some patients who love self-managing. They're an expert in themselves. I've got a couple of patients with type 1 diabetes. They would much prefer to see me every 6 months, and they have what is almost like a medical student level overview training around the condition. And so I'm really happy to spend some time every 6 months because that's what they want from me and from the system, and they do incredibly well. And then I have patients who would like to come and see me each month and other members of the team because they really don't have confidence at the moment to be really making much of an inroad into their diabetes care. And so that might involve our nurse educator, it might involve our mental health nurse. It also might involve us having a better understanding of where the patient's at. And we spent a lot of time on Tuesday talking about patient activation measures and other measures that help us to help the patient by knowing best where they fit, and then bringing in some tools that can really help them improve their confidence around engaging in their conditions. One of the articles I put up there in my presentation that we found one of the most interesting pieces of research was some qualitative research we did through our beacons with the big losers. And these were people who had shockingly poorly controlled diabetes, who were within target with their HbA1cs for a year. So that was a massively big shift. And we said to them, you know, what is the secret sauce? What is it about this model of care that has made such a dramatic effect to your diabetes care? And they said 3 things. They said, first of all, having a small team. When you have diabetes, they want you to see 8 different health professionals, and frankly, I've got other things to do with my life and I burnt out. So I really like just having the 3 key team members working with me. I like the fact they started where I was at, no matter how small the steps, and trusted me to work on those with them. And finally, I enjoyed having the health coaching, the contact weekly saying, you're doing a really good job, or hey, your sugars are not where maybe that would be best to be. Why do you think that is, and what do you think we should do? Well, maybe let's try this. So that's the different sorts of patient groups and the different sort of approach, I think, that works well for them is what they want to get the sort of health outcomes that they deserve.
Unfortunately, we've run out of time. We've utilised our time well. What I'd encourage you again to do is actually to sidle up to our speakers in the corridors over a cup of tea or coffee and actually continue the conversation. So firstly, I'd like you to thank our panel this morning.